Today, we are diving deep into some of the unsung heroes of acute poisoning. These are the compounds that save lives when the body is under siege from things like lead, mercury, or arsenic.
We're talking about chelating agents.
Exactly.
And these are, truly critical pharmacological interventions. They are often the difference between a patient surviving with minimal damage and with severe systemic failure.
And the mechanism is just so elegant because it's right there in the name,
It is. The term chelation actually comes from the Greek word chele.
which means crab's claw.
Precisely. That's the core idea. The mental image is perfect. These compounds are designed to hold a toxic metallic ion, just like a crab holds its prey.
I find that visualization so immediately memorable. The compound is literally engineered to, reach into the body and just physically grasp the toxic ion?
And hold on tight.
So our mission today is to cut through all the noise of clinical protocols. We're going to use these detailed pharmacological sources you shared to really understand the fundamental mechanics.
How these claws are built.
Yeah, well, what chemical rules they have to follow to be effective and, where their limitations force toxicologists into these incredibly complex trade-offs.
That is the core mission. The goal is a rapid shortcut to being well-informed. Because when a patient presents with heavy metal poisoning, there is just so much information overload.
Which chelator to choose, how to administer it.
Exactly. But if you understand the core chemistry and the clinical rules, you quickly grasp why the treatment has to be so specific.
Okay, so let's set the stage with those fundamental requirements. Before we even name a single drug, what are the absolute non-negotiable rules for a chelating agent to be useful in a, life or death situation?
There are two major factors that determine clinical success, and they really should govern our entire discussion today. First, the complex that the chelating agent forms with the toxic metal has to satisfy three criteria at the same time.
And what are those?
It must be chemically stable, it must be non-toxic to the body, and critically, it must be easily excreted.
So water-soluble.
Usually that means highly water-soluble. You can't just neutralize the poison inside the body. You have to successfully get it out completely.
Right. So the crab not only has to catch its prey, but it has to carry it out of the building and, dispose of it safely.
That's a great analogy. And the second factor is one of pure clinical urgency. Timing.
Timing.
The interval between the metal entering the body and the administration of the chelator is absolutely paramount. The sooner you give it,
The better the outcome.
the better the chances of reversing the acute toxic effects and limiting any permanent damage. Once that metal is tightly bound to critical enzymes or is diffused into deep tissues, it becomes exponentially harder to chelate and remove.
That sets the stage perfectly. Time is tissue and stability is paramount.
Okay, let's unpack this and start with the core component.
Yeah.
The chemistry of the claw itself. What are these molecules actually made of that gives them this incredible gripping power?
Well, the essential feature of a chelator is its ability to form a complex with a metallic ion, and in doing so, form a closed ring structure.
The ring structure.
And we get this gripping power through functional groups that we call ligands. Any useful chelating agent has to have two or more of these reactive groups.
So the ligand is the actual point of attachment. It's like the finger on the crab's claw.
That's a good way to think about it. A ligand is a functional group that can form a very specific type of bond called a coordinate bond.
And that's different from a normal covalent bond, right?
It is. In a typical covalent bond, two atoms share a pair of electrons, and each atom contributes one electron to that pair.
Okay.
But in a coordinate bond, the ligand donates both of the shared electrons to the metallic ion.
So it's being, like you said, overly generous with its electrons. Exactly. And that generosity allows the ligand to wrap around the electropositive metal center and form a highly secure, stable bond. And that translates directly into the stability we need for excretion.
And are the atoms that form these ligands just any atoms? Or are they specific?
Not at all. They're very specific. They generally involve atoms that have easily donatable lone pairs of electrons. So we're talking about oxygen, nitrogen, or sulfur atoms.
So you find them in what? Hydroxyl groups, carboxyl groups?
Exactly. Or, as we'll see with the early chelators, sulfhydryl groups and amino groups. These specific atoms provide the necessary electron pairs to really lock on to that metal ion.
This sounds like a highly specific chemical architecture. And you mentioned it forms a ring structure, the claw wrapping around the metal. Is there like an optimal size for that cage to get the most stability?
Absolutely. This is one of the most reliable rules in chelation chemistry. The ring structure that's formed is most stable when it is 5-membered, 6-membered, or 7-membered.
5, 6, or 7 atoms in the circle.
That's the sweet spot. It maximizes the bond angles and reduces steric strain, which just means it ensures the complex stays intact long enough to travel through the bloodstream and the kidneys without breaking apart too early.
That is fascinating. Okay, let's pivot to the target. Why are heavy metals so toxic in the first place? Why do we need these synthetic claws to counter them?
Heavy metals like lead or mercury, they exert their toxicity by combining with and inactivating the functional groups of critical biomolecules and enzymes in your body.
So they're attacking the body's own natural ligands.
Precisely. These metals are chemically promiscuous. They seek out groups like sulfhydryl groups on essential enzymes, bind to them, and just shut down that enzyme's function.
So the body already has these natural attachment points that the toxic metals love, and that's what causes the damage. The drug, the chelator, has to be better at attracting that metal than the enzyme the body needs to survive.
That is the core competitive mechanism. The chelating agent's primary role is to compete with the body's ligands for that heavy metal. And this requirement is so stringent that it led to the 4 essential rules of affinity that determine if a drug is even useful clinically.
This is where the toxicology gets competitive.
It really does.
Okay, lay out these 4 clinical requirements for us again, but let's dive into their clinical implications. What are the rules that let a synthetic crab's claw win this biochemical tug of war?
Rule number 1 is purely logistical: water solubility.
Right.
If the resulting complex that's later bound to the toxic metal isn't highly water-soluble, the kidneys can't filter it efficiently, the metal just stays in the body, and it could redeposit somewhere else. It's a non-negotiable prerequisite.
Got it. Rule 2 is about the competition itself.
Yes. Rule 2. The agent must have a significantly higher affinity for the toxic metal than for the body's natural ligands.
So it has to be a better binder.
A much better binder. If it binds more strongly to your essential enzymes than it does to the toxic lead or mercury, it becomes the poison itself. It has to successfully outcompete the victim's own biology for the poison.
Okay. Now, rule number 3 is often the trickiest one because it deals with the body's most common mineral.
Exactly. Rule number 3, the agent must have a higher affinity for the toxic metal than for calcium. Text 2+10.
Why calcium specifically?
Because calcium is the most readily available essential ion in your plasma and extracellular fluid. It's everywhere. If the chelator just indiscriminately grabs calcium, you'll crash the patient's calcium levels.
Usually cause what?
Hypocalcemia, which can lead very quickly to life-threatening conditions like cardiac arrhythmia or tetany.
So the chelator has to be selective enough to ignore this massive pool of essential calcium while specifically hunting the toxic invader. That is a staggeringly tough chemical requirement.
It is, and failure here means an immediate toxicity risk from the treatment itself, which we'll see when we discuss the EDTA family.
Okay. And the 4th rule.
And finally, rule number 4, which relates back to our timing discussion: distribution match.
Distribution match.
To be effective, the agent's distribution in the body has to correspond to the metal it's supposed to chelate. If the metal, let's say mercury, has crossed the blood-brain barrier and is in the central nervous system, but your chelator can't cross that barrier,
Then the treatment is useless for the brain damage.
utterly useless. It will fail to reverse the central toxic effects, and you're left with permanent neurological damage.
That is an incredibly tight set of filters. Meeting all 4 of those rules at the same time really explains why every successful chelator is so specific. You can't have a single drug for all poisonings.
No, because the chemical demands for chelating iron are completely different from those for chelating lead. It's chemistry dictating therapeutic action.
Speaking of chemical necessity, let's move into the specific agents and start with the OG, the historical surprise of the field. Let's talk about dimercaprol, or BAL.
BAL. This agent has a story tied directly to one of the darkest chapters of military history.
This is where it gets really interesting. I read that BAL stands for British Anti-Wussite. It wasn't even developed for clinical heavy metal poisoning, was it?
That's precisely right. It was a countermeasure against chemical warfare in World War II.
A war gas.
Yes. Yeah. Dimercaprol was developed in Britain as an antidote to lewisite, which is an arsenical war gas. Lewisite, like many arsenicals, exerts its toxicity by binding to vital sulfhydryl-containing enzymes. So the antidote needed to present a more attractive target than the human body.
So what gives BAL that specific defensive power? What's its core structure?
Dimercaprol is an oily, pungent-smelling viscous liquid. Chemically, its immense affinity comes from having two closely situated SH groups, two sulfhydryl groups.
So it's a direct countermeasure. If the poison uses sulfur to do damage, the antidote just offers up two highly available sulfur groups to bind to instead.
It's essentially sacrificial sulfur. Its key targets are arsenic, mercury, gold, bismuth, nickel, antimony, and copper. All of these metals have a significant affinity for sulfur-containing compounds.
Now, connecting back to Rule 1, stability is key. How does BAL use those dual SH groups to create that stable, excretable structure?
It's through stoichiometry, the ratio of drug molecules to metal ions. The most stable complex is formed when two molecules of dimercaprol bind with one metal ion.
A 2-to-1 complex.
Yes, a 2.1 complex. And that forms a stable, five-membered ring structure, which we know as the chemical sweet spot. And the stability requires maintaining an excess of dimercaprol in the plasma to maximize the formation of that 2.1 structure.
Wait, if you need an excess in the plasma for stability, but the sources say it has frequent and distressing dose-dependent toxicity, that puts clinicians in a really tough spot.
It absolutely does. It creates a severe therapeutic challenge.
Wow.
Because of its toxicity, you can't just give a large amount at once, so it forces this careful, scheduled administration.
Walk us through that administration protocol then.
Dimercaprol is given intramuscularly. It's not for oral use. You typically start at 5 mg/kg stat, then 2.5 to 3 mg/kg every 4 to 8 hours for 2 days. And then you taper down over a total of 10 days.
So it's excreted pretty quickly.
Very quickly, within 4 to 6 hours, which is why you need that frequent, consistent dosing schedule to keep plasma levels up.
But here's the most crucial caveat, the one that dramatically affects patient management and kidney function.
This is a life-saving operational detail. The dimercaprol metal complex is stable in the blood, but it can dissociate or break apart faster in acidic urine.
Uh-oh.
If that complex breaks down inside the kidney, the newly released heavy metal ion can cause acute damage to the sensitive kidney tubules, nephrotoxicity.
So the treatment itself risks damaging the very organ responsible for its removal if the internal environment isn't controlled.
Precisely. Therefore, urine must be alkalinized during dimercaprol therapy. You give agents like sodium bicarbonate to keep the urine pH above 7.0, maybe even 7.5.
And that keeps the complex intact until it's safely flushed out.
Exactly. It protects the kidney.
That turns a clinical fact into this continuous operational challenge for the care team. You're constantly monitoring and adjusting. Now, are there any metals that BL simply cannot be used for, not because it's ineffective, but because it actively makes things worse?
Yes, and this really highlights the specificity required. Dimercaprol is contraindicated in iron and cadmium poisoning
Why?
because the dimercaprol iron and dimercaprol cadmium complex is itself toxic.
Wow. So the complex designed to save the patient becomes a secondary poison in those cases.
It means that while the chelator successfully binds the metal, the resulting compound fails. Rule 1. It is not non-toxic. The Phenol or CDBL complex creates a new, soluble, toxic agent that harms the body. You have to have a precise diagnosis before giving any chelator.
What about the general adverse effects? You mentioned they're frequent and distressing. Let's talk about the patient experience.
We often refer to it as dimercaprol sickness. The side effects are frequent, they're dose-related, and they are intensely felt. It's not just a list on paper.
It's a systemic reaction.
A very intense one. Patients commonly get a significant rise in blood pressure, tachycardia, severe vomiting, burning sensations in the mouth and throat, sweating, cramps, headache, and severe anxiety.
That sounds absolutely miserable. An intense systemic crisis right on top of the acute poisoning.
It is. The reactions are so intense that clinicians sometimes give antihistamines about 30 minutes before the injection just to dampen the histamine-related effects like flushing and rapid heart rate. It's part of managing the treatment experience.
That really covers BAL, a WWII veteran of chelation, highly effective but demanding and toxic. Let's shift gears to a family of agents defined by their relationship with calcium, the EDTA family.
This transition brings us directly back to that dilemma of Rule 3, ignoring essential ions like calcium. And we have to start with disodium edetate, or textanditate.
And this one is the poster child for what happens when you fail Rule 3, right?
Absolutely. Text is a powerful, indiscriminate chelator of calcium. If you inject it rapidly, it acts like a shark, instantly pulling calcium out of the plasma and even from bone.
And that causes
Acute hypocalcemia and severe tetany, involuntary painful muscle contractions. While it can be used to crash dangerously high calcium levels in an emergency, the risks are so high that bisphosphonates are overwhelmingly preferred today.
So Texetnese today is just too good at grabbing calcium to be used safely for most poisonings. And that realization led to the creation of the safer, more specific version.
Texadiste calcium disodium editate.
Correct. The chemical breakthrough was simple but brilliant. Texdite is the calcium chelate of Texte. It's essentially preloaded.
Preloaded with calcium.
It holds calcium, but it has an even higher affinity for toxic metals like lead, zinc, cadmium, and copper than it does for the calcium it's already holding.
So it enters the body and performs a perfectly engineered calcium exchange.
Yeah.
The toxic metal swaps places with the calcium it was carrying, and the harmless calcium is released into the body. Precisely. It works by exchanging the TeX-Ta2 plus it holds for the more firmly bound toxic metal. But we should note, while it avoids stripping the body of calcium, it will also remove some essential zinc. That's an unavoidable trade-off.
What about its distribution? Does it satisfy Rule 4, the distribution match?
It satisfies the rule by defining its own limitations. TeX-EDTA is highly ionized, so it's distributed only extracellularly. It stays outside the cells.
Okay.
It's rapidly excreted by the kidneys with a very short half-life of less than an hour, and crucially, it does not enter the brain or the cerebrospinal fluid.
So since it's not absorbed from the gut and it can't cross the blood-brain barrier, it has to be given parenterally, and it can only target accessible peripheral poison stores. What's its main life-saving indication?
Acute and chronic lead poisoning. TeX-EDTA is the backbone of treatment for lead toxicity.
And what's the dosing protocol?
It's typically 1 gram diluted in 200-300 milliliters of fluid, infused intravenously over 1 hour, and repeated twice daily for 3 to 5 days.
That sounds aggressive. But lead is notoriously difficult to get rid of, especially in chronic poisoning, because it loves to hide in deep stores like bone.
And the kinetics of lead are the reason this treatment gets complex. Lead is primarily removed from soft tissues and the rapidly exchangeable pool in bone. So urinary lead excretion shoots up after the first course.
And then it drops off.
It declines rapidly as that accessible supply is depleted. The vast majority of lead is still hiding inertly in the deep bone matrix.
This is where that strategy of patience comes in, the redistribution strategy. How long do clinicians wait, and why is that interval so important?
We have to wait for the deep lead to resurface. A second course of TeX-DDT is repeated only after a 5 to 7 day break.
A full week.
That interval is vital. It allows time for the lead to slowly redistribute or leach out from its deep bone reserves into the extracellular fluid where the chelator can actually reach it. Treating continuously would just be a waste of the drug.
So you have to flush the superficial lead, wait for the deep lead to surface, and then flush again. It's a prolonged cyclical intervention.
It is. And this inability to cross the blood-brain barrier also means it's ineffective for mercury poisoning. Mercury is often too firmly bound and localized in areas, including the brain, that are inaccessible to TeX-DTA.
What about the risks with Textet? Since it doesn't cause tetany, is it relatively safe?
Relatively, yes, but not entirely.
Yeah.
The most important problem is kidney damage with proximal tubular necrosis.
Another kidney issue.
It's a dose-related toxicity. We think the mechanism is that as the complex travels through the kidney, some of the metal partially dissociates inside the sensitive tubule. This released metal then causes cell death, necrosis.
Once again, the mechanism of removal itself threatens the organ responsible for that removal.
Exactly. And this risk is minimized, just as with BAL, by rigorously maintaining high urine flow and hydration throughout the treatment. Rapid flow helps flush the complex out before it can dissociate.
That brings us to agents that have really improved the patient experience by offering lower toxicity and, crucially, oral effectiveness. Let's quickly cover succimer and penicillamine before we give penicillamine its own section.
Yes, we have to highlight dimercaptosacinic acid, or succimer. Chemically, it's very similar to dimercaprol. It has those sulfhydryl groups, but it's a massive clinical leap.
Why?
Because it is highly water-soluble, significantly less toxic, and most importantly, it is orally effective.
And being orally effective simplifies chronic or subacute treatment immensely. No more painful injections. What are its primary targets?
It's proven for arsenic, mercury, and lead poisoning.
Yeah.
It has essentially replaced BAL as the preferred oral agent for milder or chronic cases of lead and arsenic poisoning. Side effects are relatively mild: nausea, anorexia, loose motions.
And it still suffers from that common limitation, right? Essential metal loss.
Yes. Like the EDTA complex, it may also chelate essential metals like copper and zinc, so you have to monitor and potentially supplement.
Okay, now let's briefly introduce penicillamine, which we'll delve into much more deeply in a moment.
Penicillamine or dimethylcysteine, is obtained from a degradation product of the antibiotic penicillin. It's a highly selective, orally active chelator for copper, mercury, lead, and zinc.
And there's a critical point of specificity here, isn't there?
A very critical point. Only the D-isomer is used therapeutically. The polyisomer and the mixture are dangerously toxic, causing severe side effects, including optic neuritis.
The need for that D versus L specificity really highlights how sensitive the body is to minute structural differences. One is life-saving, the other is poisonous.
It's a perfect example of stereochemistry in pharmacology. The therapeutic D-isomer is well absorbed orally and excreted, markedly enhancing metal excretion.
While penicillamine is a general chelator, its most famous role is solving one specific debilitating genetic puzzle, Wilson's disease.
This is truly penicillamine's historic achievement. It was first used for Wilson's disease, also known as hepatolenticular degeneration, in the mid-1950s, a monumental therapeutic breakthrough for a previously fatal condition.
Let's define Wilson's disease for the listener. What's the root cause, and why does it lead to a copper crisis?
Wilson's disease is a genetic metabolic disorder. It's caused by a deficiency of ceruloplasmin.
And what does ceruloplasmin do?
It's the primary protein that binds and transports copper in the blood, and it's essential for excreting excess copper from the liver. In its absence, the body just can't regulate copper levels.
And what happens when that free copper circulates unchecked?
The copper begins to deposit in several key areas. First, the liver, leading to hepatitis and cirrhosis. Second, the brain, specifically the basal ganglia, causing severe neurological symptoms, tremors, difficulty speaking. And third, the cornea, creating those diagnostic green-brown Kaiser-Fleischer rings.
The copper buildup is just relentless and systemic. That explains why the therapy has to be lifelong. It's preventative care.
Absolutely. Lifelong therapy, typically 0.5 to 1 gram daily, is mandatory to prevent progression and reverse symptoms. If you stop, the copper rapidly accumulates again.
And this brings us back to that real-world challenge, adherence. The dosage has to be strictly managed.
That's the critical adherence obstacle. To avoid chelating essential dietary metals like the copper and zinc you need for normal function, the dosing must be strictly timed, either 1 hour before or 2 hours after meals.
Given that Wilson's often starts in childhood and requires lifelong adherence, doesn't that complex dosing schedule create a major risk of non-compliance? How do clinicians manage that?
It is a significant challenge. We have to educate patients and families rigorously. Taking the drug with food just drastically reduces its effectiveness. By letting it bind to inert dietary metals, it wastes the dose.
So you're constantly monitoring.
Constant monitoring of plasma and urine copper to ensure compliance and effectiveness, and often adjusting the timing and dose to fit the patient's lifestyle.
Outside of this specialized copper dumping role, what are the other critical applications for penicillamine?
It's used as an adjuvant of supplementary treatment alongside dimercaprol for acute copper poisoning. It's also used for chronic lead poisoning, though we prefer Suxamer now because of its better toxicity profile.
But it goes beyond heavy metals, connecting surprisingly to renal stones. Tell us about the cystinuria connection.
This is one of its most fascinating non-chelation applications. Cystinuria is a genetic condition with high concentrations of the amino acid cysteine in the urine. Cysteine forms a very poorly soluble compound called cysteine, which precipitates and forms painful, recurrent kidney stones.
So how does penicillamine solve this problem?
It treats this by chemically reacting with the cysteine. It doesn't chelate a metal here. It increases the excretion of cysteine by forming a highly soluble penicillamine-cysteine complex.
And that complex is more soluble than the cysteine that forms the stones?
Much more soluble, so it effectively prevents the precipitation of the insoluble cysteine stones.
Yeah.
It's essentially a solubilizing agent for the stone precursor.
So it's a chelator, a stone dissolver, and it even has a role in treating a connective tissue disorder, scleroderma. It's an incredibly versatile molecule.
Yes. In scleroderma, a disease involving hardening of the skin and connective tissues, penicillamine provides a benefit by increasing the amount of soluble collagen.
It seems incredible that a metal chelator can affect soft tissue like that. Is it removing a metal, or is the benefit purely structural on the collagen itself?
The mechanism is complex, but it's believed that penicillamine interferes with the cross-linking of newly synthesized collagen molecules. By disrupting these cross-links, it makes the collagen more soluble and less prone to the excessive hardening that's characteristic of scleroderma.
Given all these uses, particularly the need for lifelong application in Wilson's, What's the trade-off in terms of its toxicity profile long-term?
The toxicity profile really depends on the duration of use. Short-term use for acute metal poisoning is generally tolerated.
But long-term.
However, long-term use, like the lifelong therapy for Wilson's, produces pronounced and serious toxicity across multiple systems. We see severe dermatological issues, significant renal problems, hematological toxicities like bone marrow suppression, and other collagen tissue toxicities. This requires relentless, comprehensive patient monitoring.
That is a stark trade-off. Lifelong stability against a genetic disease versus decades of managing severe systemic toxicity.
It highlights the constant compromise in toxicology.
Now let's tackle the challenge of iron. Iron poisoning and chronic iron overload require a completely different set of chelators because iron is so abundant and integral to the body's machinery. You can't just throw a general metal chelator at it.
Iron is a unique challenge. Acute iron poisoning is very common, often in children, and requires immediate life-saving intervention. And chronic iron overload or transfusion siderosis is frequent in patients with thalassemia. For this, we turn to dysferrioxamine.
The original iron wrangler. Tell us about dysferrioxamine. Where does it come from and how is it so specific for iron?
Dysferrioxamine is a complex derived from an actinomycete, a type of bacteria. When you chemically remove the iron, you get dysferrioxamine. And it has a remarkably high selective affinity for ferric iron.
How much can it chelate?
1 gram of dysferrioxamine can chelate 85 milligrams of elemental iron.
And its chemical magic is that it knows the difference between the bad iron and the good iron.
That's right. It removes the loosely bound stored iron, the iron in ferritin and hemosiderin, which is the overload. But critically, it does not remove iron from hemoglobin or essential enzymes like cytochromes. That selectivity makes it safe.
And it perfectly respects the crucial Rule 3, the calcium rule.
Yes. It has a minimal affinity for calcium, which is highly desirable. It satisfies Rule 3 perfectly, so no risk of tetany.
What are its two primary life-saving clinical uses?
Number 1, acute iron poisoning. This is often life-saving, given as a continuous intravenous infusion. Number 2, transfusion siderosis. It helps excrete that chronic iron load, often given intramuscularly or intravenously during the transfusion itself.
How is it administered and what are the major side effects?
It's poorly absorbed orally, so it has to be given parenterally, either deep IM or IV. The major acute side effect is histamine release.
Which causes what?
A drop in blood pressure, flushing, intense itching, hives, a variety of pseudoallergic reactions that can be quite intense.
Given that patients with chronic siderosis need lifelong chelation, having to rely on frequent daily parenteral injections must be a massive burden on their quality of life.
It was an enormous quality of life burden. Patients required specialized infusion pumps for nightly subcutaneous injections lasting 8 to 12 hours for decades. This compliance issue was the driving force behind the search for effective oral options.
The oral revolution. Let's look at the first agent in that revolution, deferiprone. How does it simplify treatment?
Deferiprone is orally active. It allows patients to switch from those continuous nightly infusions to just taking a tablet, which dramatically improves adherence and quality of life.
Is it as effective as the injected dysferrioxamine?
Pharmacologically, it's often considered a somewhat less effective alternative than the maximum injected dose. But the convenience of oral administration, combined with fewer side effects and lower cost, makes it a valuable first-line option.
What are the trade-offs in terms of side effects for deferiprone? Any serious risks?
The common side effects are anorexia, vomiting, altered taste, and joint pain. The most serious concern, which requires strict monitoring, is reversible neutropenia, a drop in white blood cell count. Rarely, a granulocytosis can occur, making regular blood counts essential.
And finally, the modern choice, which seems to have been designed to minimize the essential metal loss problem we've been discussing, deferricirox.
Deferricirox is the more recent oral iron chelator and represents a major step forward. It is highly effective at lowering serum ferritin and hepatic iron concentration.
What is its key chemical advantage over the earlier agents?
Its key feature is its tailored specificity. It has an exceptionally high affinity for iron, but a remarkably low affinity for other essential trace metals like copper and zinc.
So it reduces the risk of creating an essential metal deficiency during treatment.
Exactly. It addresses one of the core challenges of chelation therapy.
And how is the dosing regimen?
It's well absorbed orally and needs simple once-daily dosing. It's usually dispersed in water or juice and taken on an empty stomach. And unlike the earlier agents that were excreted by the kidneys, deferricirox is primarily excreted in the bile.
Does this modern solution come without risk?
No, but the profile is generally manageable. Common side effects are nausea, headache, and rashes. However, clinicians must vigilantly monitor for less frequent but more serious effects, specifically GI ulceration and hemorrhages, and signs of renal failure.
This journey through the science of the crab's claw really synthesizes a core principle of toxicology, doesn't it? Chelating agents aren't a single class. They're highly specialized, chemically demanding tools.
Absolutely. The core takeaway for you, the listener, is that these life-saving drugs are defined entirely by their chemical architecture, the ligands, the stable rings, the unique affinity profiles. You need Phe-specific wranglers, SHGU-specific binders, or PB-specific exchange agents.
And the difference between a life-saving drug and an actively toxic compound often comes down to one molecule's ability to navigate those four rules: water solubility, high affinity for the poison, disinterest in calcium, and matching the bodily distribution of the poison.
Precisely. And if we connect this to the bigger picture, knowing the distribution, whether the drug stays extracellularly like TXT-DET or can get into the central nervous system, is critical. You have to understand the potential adverse effects, from the acute misery of histamine release to the severe renal toxicity.
And timing is everything.
And remember, the initial rule, the timing of treatment is critical for maximizing efficacy and reversing the toxic effects.
It's a delicate, precise, and highly complex dance between chemistry, timing, and minimizing collateral damage. So we've learned today that while modern agents like Difersarox have made huge strides in targeted removal, many other agents, like Suxamer or Textitae, still pose a risk by inadvertently chelating essential metals like zinc and copper.
It's a known complication.
So here's a final provocative thought for you to mull over. If the margin of safety often relies on an agent not chelating these essential trace elements, and yet we know zinc and copper deficiencies can be complications of these treatments, how fine is that required balance between saving a life from acute poisoning and then managing the resulting essential metal deficiency? And what does that persistent reliance on such minute quantities of these trace elements reveal about the fundamental fragility of the body's own internal chemistry?
A fascinating area that continues to drive pharmaceutical chemistry towards even greater specificity and reduced collateral damage.
We'll catch you on the next deep dive.